Thank you so much, and thank you very much for the invitation. It's a fantastic opportunity to be able to talk with you all. I know a very high-powered group of people. So what I want to do is to talk a little bit about some of the issues that we have encountered from ECDC's point of view, from the EU's point of view, in terms of trying to promote behavioral sciences and BI for the different governments across the EU over the course of the pandemic. So first of all, in case you're not familiar with ECDC, we are an EU agency, so we work for the EU. We serve the Commission and we serve the member states. So our task is really to provide guidance and support for the activities that they are doing. And specifically, the European Centre for Disease Prevention and Control, there's no P in there for the prevention bit, but it probably ought to be. What we do is all about infectious diseases. So we don't do NCDs, it's all infectious diseases. And there are a number of different things that we do, and I've listed several of them here. Surveillance, which is really, really core, and that's really what the sort of preeminent capacities of ECDC revolve around, and alongside epidemic intelligence, preparedness and response, microbiology, training, and then MyBit, which is social and behavioral insights, and health communication. So what we have done over the course of the pandemic, a lot of the work has been in other areas has been deprioritized, and we've provided a lot of input on COVID-19 response to the member states over the course of the last 2 years. So what I want to do to sort of kick off here, I want to talk about a survey that we did in the end of 2020 and the beginning of 21. Notably pre-vaccine rollout. In other words, that's an important sort of point to bear in mind. When it was becoming clear that we didn't really know very much about what the different countries were doing in terms of behavioral insights or BI, we have systems in place for how we reach out to all the member states. There are very particular protocols that you follow. You don't just write to your friends. You have to go through certain nominated people in each country to do different activities. So we wrote to the relevant people in all of the then 31 countries. That would be including the UK at that stage. So we've got 27 EU countries and 3 EA countries, which includes Liechtenstein, Iceland, and Norway. And it was quite an effort to get people to respond to this. In the end, after 4 rounds of reminders and gentle shoves, I got 10 people to respond. So 10 countries took part in the end out of the 31, which I think in itself is already an indication of something, which may be that we don't know exactly who the right people are to talk to, or it may be that it's not a particular priority in the countries. I'm not quite sure, and that's conjecture, but it definitely tells us something. So here we've got the 10 countries that did take part. You can read through them there. Cyprus, Denmark, Finland, France, Germany, the Netherlands, Norway, Slovenia, Spain, and Sweden. And straight away, you can see, if you kind of map that, and I'll show you a map a little bit later of where these all are, you can see that there is a bias towards the north and the west. Again, that's an indication of something that we need to think about. So what we did was to talk to the experts from the, and by the way, Marijn was one of the people I spoke to. He was the representative from the Netherlands. And we wanted to understand how BI findings have been integrated into decision-making processes during the pandemic. So overall, remember, of course, this is just 10 countries, but I can give you a snapshot of what we found. The predominant research has been quantitative, using serial cross-sectional surveys, which of course has the advantage that you can then see trends over time if you have nationally representative samples. That's clearly the advantage of that. Some qualitative research was being done, but not very much. And I'm an anthropologist myself, so to me this is something which I think is important, and it's a gap that we need to be looking carefully at to see how we can fill that. Why was it not being used in limited capacities in many countries? It's time consuming, and the resources and staff were not available for that particular work to the extent that, for example, the quantitative work was. 4 of the 10 countries used the Cosmo tool, which has been developed by WHO Euro. And Cosmo was a COVID-specific survey tool, which was developed by them for use by the WHO Euro member states, which stretches all the way to the Pacific, actually. Vladivostok. So all of the sort of countries from the EU, East, covering many different topics. And the topics changed over time, of course. It was initiated in April or March of 20. And so, of course, as vaccination came in, new questions were added and some questions became redundant. But at this stage, when we did the interviews, the most commonly studied area that the countries were looking at was to do with population acceptance of and compliance with or adherence to the NPIs. So to what extent are the findings actually going through into the decision-making process? Excuse me. Well, what we noticed with the 10 countries was a real spectrum. In some cases, it was the right people were sitting at the table, and in other countries, it was extremely difficult to get behavioral insights findings actually into the process of the decision makers' thinking. In many countries, the problem was that BI was not really very well integrated into the management teams. And the social and behavioral scientists were not really represented to the extent that many other areas of expertise were, and clearly the predominant areas. And I don't think this would be much of a surprise to you, but it was extremely clear from the interviews that this was the case in the countries that we were speaking with. There were in several countries different institutions at quite high level doing different behavioral insights work. And for example, you could have one country where this sort of work was being done by the Ministry of Health, by the National Institute of Public Health, and by the President's Office or the Prime Minister's Office. So high level work being done, but not always coordinated, which is then problematic because you don't really know which data are being used and would there be cherry picking or would there be a way of bringing everything together so there's a really good kind of synthesis of what's going on. Of course, we also found many of the countries funding a lot of COVID BI research in the universities, but once the money went out and the researchers are doing the work, there wasn't a clear avenue back to the decision makers. So there's a big problem there in terms of good data supported by the country, by the country's own bank, but it's not being used because the mechanisms were not in place for that purpose. So these were clearly issues to do with information finding its way to the right place. And I noticed also over discussions over the last year during 21 and to some extent this year also, that things have been improving. So I think the pandemic has actually stimulated more coordination and more bringing together of different data, but still we clearly have a long way to go. Here's the map I mentioned. The red countries are the countries that took part, and you can see it's completely over to the west and to the north with an almost clear absence except for Slovenia and Cyprus towards the southern and eastern side. So that tells us quite a lot, I think. And particularly last year, towards the end of the year, when we had an extremely high level of infections in, for example, Bulgaria and Romania, with very concomitant, very low levels of vaccination, it's quite clear there's a need to understand in much more depth the reasons for that low level of vaccination. For sure, a lot of it has to do with access, but equally for sure, a lot of it has to do with misinformation and general reluctance on the part of the population. So understanding that, however, was the understanding of that was very limited. So what we have here on this kind of shadow area towards the east and central side of Europe is a higher need, but less capacity in terms of behavioral insights, which is something that we as the EU we were very concerned about this. And so we were really focusing on this. And again, right now with the Ukraine crisis, you can see the 4 countries, EU countries that border Ukraine, Poland, Slovakia, Hungary, and Romania. These are also countries that we're now very much focusing on to try and provide more support to them in understanding the needs of both their own populations with vaccination, but also the people coming in from Ukraine who are under-vaccinated in many respects, and now we're particularly concerned about outbreaks of measles and possibly also polio. So, to what extent has BI actually contributed to decision-making? It's, again, not surprising to you, I'm sure, but it's very, very difficult, if not impossible, to really quantify this. to actually have your findings and your decision, there's a big black box in the middle, and to say the extent to which this is fed in is very, very difficult to say. But I think what we can conclude, and what we have concluded, is that the behavioral insights in many countries has often provided a nuanced understanding of how things are happening and how people are acting and understanding the situation. And therefore, implementation plans have been facilitated, let's say. Been a particular policy that has come out specifically of a particular finding or set of findings, but rather that implementation has been improved. Operational plans have been made better. Also, looking retrospectively, BI has acted as an evaluation tool in the sense that you can see something as a policy has come in, and then you can see how the population has responded to it. So it's been more retrospective rather than formative in the sense that it defines the policy and then moves forward. And of course, this is where I think a lot of your focus is here. Are we looking at process or are we looking at impact? And I think we can conclude that BI has done very well in providing an understanding of process, which NPIs the populations are willing to accept, to what extent are the people adhering to the measures, and how can vaccination coverage be optimized? Three of the core issues which clearly have happened. So that, as I say, process has been good. But if you're trying to say this NPI works, or this NPI doesn't, or this one is more effective than this one, excuse me, it's much more difficult to actually ascertain effectiveness. And here we're relying on the RCTs, which I've listed here some of the problems as I see it: time-consuming, expensive, logistically challenging, ethically sometimes problematic. And what are we actually assessing, the efficacy or effectiveness? There's also the question of to what extent would an RCT conducted, say, in Galway be relevant in Budapest? The results of that would be meaningless, potentially, because the cultural context or the political context is so different in Budapest as compared to Galway. The trust issues may be completely different in terms of what people are listening to and believing in from what they're hearing from the authorities. So it's a really, really big problem using the findings from RCTs from one context and applying them in another. And this is, I think I'd be really grateful for some discussion around this, because I think this is a big problem. And in fact, it's the same slide that appeared at the beginning of this, which I thought was really interesting. That you also wanted to show this, because to me this says a lot. It says, first of all, these topics are much more difficult to do using RCTs, to evaluate using RCTs. And secondly, of course, the capacity to do that isn't there, as you pointed there at the beginning. So effectively, we have some sort of methodological bottleneck. The contrast here between the drug trials and the BESSI trials is enormous. Obviously, RCTs were designed for drugs; they weren't designed for behavioral interventions. And I think that's we have this sort of very often this thinking, well, we must apply the RCT to behavioral interventions, but I think it's and to just make that simple leap from one completely different type of intervention to another. And I think this figure really illustrates that. So what we need to, perhaps my proposal would be to be thinking about here, if we're looking at a sort of methodological wish list, we really need to be looking at other methods for evaluation. And I've listed here realist evaluation, which I recognize is quite complicated and it requires a very particular skill set to be able to do it, or operational research, which is essentially the science of better improving things again. But really we need methodological innovation. We need more inclusion of methods that specifically take context into account, and part of that, of course, can be brought about through qualitative data. And we also need much better collaboration between academia and the National Institutes of Public Health. Another big issue, of course, is getting the ear of the people who are making the decisions. How do you get to that table? And one of the things we found from these discussions with the 10 countries is that the right person isn't always there in the right place at the right time. And there are certain individuals we spoke to who were able to maneuver themselves into exactly the right spot. They have strong understanding of BI, they're well connected and they're politically savvy. And they were able to maneuver themselves and get in, but that's not always the case in all the countries. So therefore you might have good work simply not making it to the table. Another issue we need to think about is the hierarchy we're working within, which is that essentially we are low on the hierarchy in terms of where we sit with regards to the epidemiologists or the immunologists or the virologists. I think we all know this. That's the fact. And I think therefore what we need to do is to raise our game even better, so that what we're doing is very solid, very convincing, and above all actionable, not fluffing around with, oh, it could be this or it could be that. I think we have to slightly avoid the hedging, and we have to be quite committed about what we should be doing, because decision makers want answers. They don't want more questions and problems to think about. And that, I think, is a problem, because we're always dealing with context and nuance and all this, and that is, again, methodologically very challenging, but we need to think about that. And another thing we need to think about is, especially during the pandemic, which was very, very exhausting, because we were constantly moving into uncertainty and fresh uncertainty and fresh uncertainty again. So what, as I say here, what I thought I knew last month is no longer relevant, or is it? I'm not quite sure. A new intervention, whether it's vaccination or something else, a new variant of concern, a new wave. So constantly changing situation, constantly not knowing what we should be doing. And our task as behavioral scientists, I think to some extent, is to help decision makers deal with that constant uncertainty. Now, the apparent passing of the pandemic. We've seen in many countries, sadly, a lot of COVID infrastructure is already being dismantled. Obviously, it's expensive, but I think we all know that the pandemic is not over. We're in, as the WHO Euro head, Hans Kluge, said, we're in a ceasefire at the moment. And there will surely be new variants. There will probably be an upsurge in the autumn. And yet we're now flying blind. Testing capacity is going down, sequencing capacity is going down, BI capacity is going down. And of course, our problem is, since we're relatively low in the hierarchy, is that it may be more difficult to get BI capacity and infrastructures rebuilt in the event of a new wave or a new VOC. So we need to be absolutely hammering at the door to make sure that what we have built now remains to the extent that we can keep it. The structures and the capacities that we build have to be institutionalized to the extent that it's possible. And as I say here, before the next crisis, well, unfortunately, it's already too late for that. We're already in the next crisis. And of course, decision makers' attention is therefore very much on that. But to avoid that loss of experience and skills, we need to do what we can to make sure that our voices are still heard and that we still have the work that we can do. So 4 things that I think we need to do now. Number 1, document and demonstrate what we've actually contributed to the pandemic response to date. We need to show that we've actually really contributed here in very real terms. We need to institutionalize capacities so we don't lose the expertise and infrastructures. And I think that's largely dependent on the extent to which we can do number 1. So the money and the resources will continue to come. We need to address disparities in the capacities across the EU. As I said, the Central and Eastern European countries have clearly got problems in not having as much as many other countries do. And we also need to think carefully about methodological development, the evaluation of behavioral interventions.